Welcome back, focused learners, to part 56 of our 150-part IPDRG masterclass. I am your lead instructor. Now, before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, so in part 55, we wrapped our heads around pre-MDCs and those special grouping rules for things like ECMO, transplants, and tracheostomies. Today, in this explainer, we're taking a huge step forward. We're going to break down exactly how the healthcare system translates complex clinical realities into critical metrics of severity and risk by tackling the fundamental differences between MS-DRGs and APRGs. Here's a quick look at our agenda for today. We'll trace the evolution of DRG systems, compare the Medicare-focused MS-DRGs with the all-patient approach, unpack the dual-axis structure of severity of illness and risk of mortality, dig into the complex grouping mechanics, and finally wrap it all up with a summary. Let's get right to it. Section 1. The evolution of DRG systems. To really understand where we are today, we've got to establish how diagnosis-related groups actually started. It's been quite a paradigm shift over the decades. It all kicked off with the original DRGs developed by Yale University back in the 1980s, which grouped stays primarily by principal diagnosis. From there, we evolved to APDRGs, which brought in pediatric and obstetric refinements. Then came the APR-DRGs, heavily utilized by state Medicaid programs, introducing a really crucial 4-level severity scale. And finally, we landed on the CMS MS-DRGs, introduced in fiscal year 2008, which differentiates stays primarily by severity and comorbidity. So the crucial takeaway here is that a DRG basically takes a wildly complex, highly individualized hospital stay and standardizes it. It operates on a pretty straightforward formula. Clinical similarity plus resource similarity equals one payment group. The expectation is that every patient in a specific group will consume roughly the same amount of hospital resources. And, that expectation is the absolute foundation of the inpatient prospective payment system. Section 2, MS-DRGs, the Medicare standard. All right, let's look at the system most of you are intimately familiar with, the Medicare Severity DRG. The MS-DRG grouper relies on a very specific set of inputs pulled straight from the medical record. Your principal diagnosis determines the base family, while your procedures can actually shift the patient from a medical to a surgical DRG. But here's what you always need to remember about its core identity. This system's ultimate design philosophy is geared primarily toward the Medicare and elderly population. Because of that focus, MS-DRGs utilize a highly structured triplet tier system. Think of it essentially as checkbox logic. The presence of just a single binary CC, a complication or comorbidity, or an MCC, a major complication or comorbidity, instantly increases the relative weight and the reimbursement of the case. So for example, if a patient is admitted for simple pneumonia, well, that's your base tier. But if they also have acute renal failure, bam, that single MCC acts as a trigger to bump them right up into the highest paying tier. Ultimately, this entire MS-DRG architecture is built to answer one primary question: how much is this specific Medicare patient going to cost to treat? It's all about measuring resource utilization. In fact, an MCC is literally defined by the fact that it significantly increases hospital resource use. So while it's a fantastic tool for predicting cost, it isn't always a perfect reflection of how physically sick the patient actually is. Which brings us to Section 3, APR-DRGs, the all-patient approach. So what happens when the patient isn't an elderly Medicare beneficiary? What if you're coding for a pediatric patient, an obstetric case, or a Medicaid beneficiary? This is where the 3M all-patient refined system steps in. It represents a massive evolution because it shifts the core focus away from pure cost and points it directly toward actual clinical severity. Instead of just asking, how much will this cost? It asks, how sick is this patient, and what is their risk of a bad outcome? It handles these diverse, all-patient demographics with a level of nuance that the MS-DRG system just simply wasn't designed for. Let's break that down in Section 4, Understanding SOI and ROM. To achieve this broader, much more clinically accurate focus, the APR-DRG framework completely abandons those simple checkboxes we just talked about. Instead, it utilizes a fascinating dual-axis structure. The first axis is SOI, or severity of illness. So rather than just tracking resources, this axis measures how physically sick the patient actually is on a physiological level. It's looking at the extent of organ system loss of function. Think about it. A patient might not consume a ton of expensive resources, but their body could still be shutting down. SOI captures that very real clinical reality. Simultaneously, the second axis, ROM, or risk of mortality, evaluates a completely separate metric. It looks at the actual risk to the patient's life, specifically the medical likelihood of them dying during that inpatient stay. You could absolutely have a patient with a high severity of illness who requires intense, complex treatment, but thanks to modern medicine, their actual risk of mortality could be quite low. APR-DRGs are brilliant because they track both of these metrics independently for every single inpatient stay.
And what's really interesting about this framework is that both SOI and ROM are divided into 4 exact subclasses. Subclass 1 is minor or mild, 2 is moderate, 3 is major or severe, and 4 is extreme. That means every single patient receives a distinct 1 to 4 grading for both their severity and their mortality risk. So you're no longer just looking at a patient with an MCC. You have a patient with an SOI of 3 and an ROM of 4. It paints a much clearer, more precise picture.
Moving on to Section 5, Complex Grouping Mechanics. Now, you might be wondering, how do we actually arrive at these precise 1 to 4 subclasses if we aren't just checking binary boxes? Well, APR-DRGs eliminate those simple lists and instead evaluate complex comorbidity interactions. The grouper looks holistically at how multiple chronic conditions, the patient's age, and specific procedures all interact together to elevate the patient's severity. For instance, 2 moderate conditions in an 80-year-old might interact to create an extreme severity, whereas those exact same 2 conditions in a 20-year-old might only trigger a moderate severity. It's all about context. This step-by-step matrix ensures that your precision in clinical documentation directly drives the final, highly nuanced severity assignment. It works like this. First, the principal diagnosis sets your base APR-DRG. Then, the logic engine calculates the SOI subclass from 1 to 4 based on all those interacting factors. After that, it repeats this complex calculation entirely independently for the ROM subclass. Only after all of that number crunching do you get your final DRG assignment.
Because of this highly interactive system, precise medical coding and documentation is absolutely crucial. If you use a vague term like heart failure, you completely lose the nuanced interactions required to accurately reflect an extreme severity. But if you document acute on chronic systolic congestive heart failure, well, now the grouper can link that specific physiological decompensation with other secondary diagnoses. That dynamically drives up the patient's SOI and ROM to reflect reality.
Let's bring it all together in Section 6, Summary and Final Thoughts. Let's synthesize everything we've uncovered today about these 2 powerful classification systems and what it actually means for your daily work. Well, MS-DRGs provide a fantastic structured framework for resource allocation and cost prediction among Medicare patients using straightforward logic. APR-DRGs offer a much more comprehensive and clinical view of reality for all patient demographics. They do this by looking at true physiologic decompensation using those complex interactive 1 to 4 scales. Whether you're calculating a single MCC to secure proper reimbursement for a Medicare claim, or you're mapping a complex web of interactive comorbidities for an APR-DRG extreme mortality risk, precision is everything. As our sources explicitly state, accurate and specific clinical documentation is truly the lifeblood of the IPDRG system. You simply can't game it, you have to document it. As you navigate these coding systems in your career, I want you to ask yourself this final question. Does your documentation merely check a list of boxes, or does it capture the true, nuanced severity of the human life in the bed? Let that thought guide the precision of your future work. That wraps up Part 56 of our masterclass. Make sure you join us next time for Part 57, where we're going to dive into the fascinating post-acute care transfer, or PACT, policy, and explore the profound impact of discharge status codes. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep learning, keep pushing yourselves, and I will see you in the next explainer.